Hi, today I'm going to discuss case number 2 of the homework of course number 725. So we have a 16 years old male, Middle Eastern in origin. He came requesting to get braces. The patient has been seen by his dentist who recommended ortho consultation before she finalizes her restorative plan regarding to poorly prognosed molars and also the over-erupted of the upper molars. Patient has no pain currently. The patient medical history, he was diagnosed with diabetes when he was 8, of course, diabetes type 1, and the first sign was frequent urination and thirst. His father is a physician, so he started him on insulin therapy immediately after he was diagnosed and confirmed with lab work. At age 10, the patient started to become very lazy and tired and started to gain weight. Although he was well managed by insulin, so they checked the thyroid gland and thyroid hormones, and they found that it has hypothyroidism. So he was started on that medication, thyroxine. So currently, the patient is taking the thyroxine as well as the insulin injections to control the diabetes. Upon clinical examination, patient has normal range of motion on opening and lateral excursion, as well as normal TMJ. Muscles of mastication has no pain on palpation. Occlusion-wise, patient is class 1 canines, and we will see in a second the pictures of his intraoral pictures that shows the molars cannot be established, the relationship, because there are no more crowns in the lower, and he has normal overjet and overbite, and he has mild to moderate crowding in the upper and lower. Soft tissues are normal, and periodontally he has generalized gingivitis with recession on lower left 1, which we think is due to excessive occlusion or high point due to the occlusal situation that he has. He has very bad oral hygiene. So as we can see in the intraoral pictures here, the lower right 6 and lower right 7 are deeply decayed with fractured crowns. And we see the lower left 7 is also deeply decayed with fractured crown as well. And the lower left 6 has only remaining roots now. The endo treatment, there is endo treatment on the upper left 2, upper left 5, and upper left 6. Wisdom teeth are erupted in the lower quadrant, and generalized plaque and staining is present on all teeth. As well as we can see the over-erupted upper molars due to the absence of a crown to hold the bite from the lower molars. When we look at his panoramic X-ray, we can see that we have a periapical radiolucency around the remaining roots of lower left 6, as well as we have periapical radiolucency a little bit around the root of lower right 6, but there is a huge radio-opaque lesion associated with that tooth. It seems a very dense color radio-opaque lesion. Other than that, this X-ray confirms the endo treatment that we mentioned on the upper right 2, 5, and 6. And there is kind of funny crown, or I need to investigate this more with the general dentist if this is a bridge kind of connecting the 5 and the 4 on the upper left side, or whether they are separate. And we can see the remaining roots of the lower left 6, and we have the wisdom teeth on all quadrants, normal condyles. So the plan was to first start with scaling and root planing and establish the good oral hygiene before we can consider starting ortho treatment, because as we know, hygiene becomes more challenging with braces. So before we start, we need to make sure that the patient is able to take care of his braces and his hygiene before we start, so that we don't end up with multiple decalcification and caries. Then I will discuss the prognosis of the sixes and sevens in the lower with the dentist to decide if my ortho plan should be based on the extraction of these teeth or saving them. Lower sixes, in my opinion, has to go, but not sure about the sevens. I would like to request a CBCT to evaluate the location of the lesion and whether it will affect my ortho work. I'm not sure. It seems to me that we will extract the lower right six, but if this bony lesion or condensing bone osteitis is in the way, I'm not sure if I can be able to move the seven around to replace the six with the ortho treatment. So I need to investigate the location and also to see how much is close to the infraalveolar nerve and whether it's worth removing it or not. We will discuss, of course, with the oral surgeon about this radioopacity and whether it can be removed or needed to be removed or not before ortho treatment. And based on the restorative dentist and oral surgeon feedback, we will finalize our ortho plan whether to mesialize the 7 and 8 to replace the 6 or keep the space for future implant or prosthesis. And of course, education of the patient with diabetes is very important. We need to remind them and their caregivers that daily and regular routine of dental care is essential for the treatment and metabolic control of diabetes, and that diabetic patients must be educated regarding the impact of oral hygiene on their treatment, and as well as to make sure that they eat proper and they avoid sugar and they keep good regular oral hygiene and brushing routine. And of course, the importance of nutrition on the overall health of their gum. So what about the lesion? We sent the patient to the surgeon. He gave a differential diagnosis of either condensing osteitis or cementoma. He said that the cementoma usually has a tendency to push the teeth lingually, as the case in here. But because this tooth is also having a periapical and endo involvement, he said many times it does develop condensing osteitis as a reaction to the inflammation. He recommended that we can start ortho treatment. We can attempt to move the lower right 7 mesially, but with very, very gentle force, or instead to restore prosthetically the area with either an implant or a bridge after we finish ortho treatment. He also recommended that we monitor the lesion. If it starts to get bigger or cause problem during our ortho treatment, we can remove it. So, visit number 1 with the dentist was to get the scaling and root planing and oral hygiene instructions and to check if there is any caries exist and to treat that. Morning appointments, of course, was given and the patient did very well. After 1 week, extraction of the remaining roots of lower left 6 by the dentist was done. The patient was doing very well as well. After 1 week, healing is good, and extraction of the lower right 6 by the oral surgeon was done because it was related to the osteitis, and he preferred with the dentist that he will do it in case the root will break or there will be a complication, that he can deal with the situation better than the dentist. So he decided not to remove the radioopacity, as we said, and to keep it and monitor it. Visit number 4, after 1 week, we started upper braces, and after 1 month, we started with the lower braces. What are the things we need to be aware of when we do braces for people with diabetes? So the question is, can we move the teeth into a sclerotic bone? And that was a very interesting topic for me as a dentist, because we usually, when we look at sclerotic bone, we don't prefer to move teeth around because we are always afraid of root resorption. So I reviewed this paper by Consolaro in 2012, and he stated that there's a difference between focal sclerosing osteitis versus idiopathic osteosclerosis. He said that the inflammatory osteitis is usually located mainly in an area where there was an inflammation, just like an endo or perio lesion, and it's usually a slow progression and not aggressive, it's less aggressive. So the body kind of makes osteotic bone as a reaction to this inflammation. And this is the histological view of this focal chronic sclerosing osteitis that shows the reduction of the medullary space, which is filled with conjunctive tissue like a discrete and diffuse mononuclear infiltrate. So we can see how the trabecular is thicker and with well-defined layer of apposition. In contrast, this is a radiograph of the idiopathic sclerosis which has no real cause-effect identification. Maybe in the past there was some kind of low intensity and long duration trauma that may have happened in the area leading to this sclerotic area, but usually this area is doesn't disappear with constant as in normal remodeling of the bone with ortho treatment. So, can we apply ortho forces, whether it's osteitis due to inflammation or idiopathic? What special considerations we have to make before we start the ortho treatment in that sense? So we need to learn the new bone biology and the reaction between the forces of ortho to the lesion around it, how they interact. So, as we know, in a normal situation, when we put ortho forces, there will be a natural deflection in the bone due to our forces, and that leads to the process gently happening on the resorption of the bone and the moving of the tooth. In a case when we have osteosclerosis of the bone, that deflection is almost absent or insignificant. So then the forces that applied on the tooth will tend to focus on its full potential on the periodontal ligament, which contains cementoblast, which protect the integrity of the root. Then hyalinization area may be established by leakage and cell death despite conventional orthoforces that are applied. So, because there is no deflection due to the higher bone density, normal and conventional forces become dangerous to the tissue ligament during tooth movement along areas of the idiopathic sclerosis. So, any force applied to the teeth in dense area directly affect the periodontal ligament. So that's why we have to be very careful with our tooth movement into the sclerotic bone area. And in cases when we need to move the teeth through denser area, such as idiopathic osteosclerosis, bone type, the ideal would be to use smaller forces than the conventionally employed, because the bone deflection, as we said, doesn't happen due to the higher density on site, and instead we need to use very slow forces that can compensate for the non-deflection, and by reducing that force we can surprisingly move the tooth in a normal and even faster movement in a denser area. And some questions that could be answered in future work are like, what is the prevalence of root resorption in teeth that were moved in areas of dense bone by other dentists or orthodontists with or without the care we mentioned earlier with low forces and not our conventional ortho forces? Do we have more increased root resorption? What is the prevalence of root resorption in teeth that were orthodontically moved along denser cortical bone? Because many times we face cortical bone as well in our way of tooth movement, whether we are retracting upper incisors after extraction or lower incisors, or even moving molars across the ridge, which might be in touch with the cortical bone. And finally, what would differences in the frequency of root resorption in some types of teeth be related to bone density and the thickness of the cortical bone, features which vary in the different segments of the jaw? because many times we see more root resorption, for example, in the upper incisors and lateral centrals and lateral incisors, as well as molars. So could it be due to the different bone density and the closeness of the cortical bone to the roots of the upper incisors and the different denser bone around the first molar that can be a reason for more root resorption in these teeth, although we are applying the same force on every single tooth? So these are all important questions that we might be able to research them and investigate about them in the future. And these are the references. Thank you.